alaikum. Good morning, everybody. I'm going to talk about IBS versus IBD, common start and different ending. Actually, I wonder how accurate the title is, as the current evidence now showed that the prevalence of IBS among IBD patients is high compared to general population. Not only that, but also the risk of IBS and IBD increase after exposure to infectious gastroenteritis, and having IBS itself is a risk factor for future development of inflammatory bowel disease. And actually there is overlap and similarities between the two diseases in terms of symptoms. In other words, what I'm trying to say is that despite difference in clinical morbidity and pathophysiology between IBD and IBS, both may represent a spectrum of one disease, whereby IBS may represent a subclinical inflammation and immune activation that may progress in the future towards expression of inflammatory bowel disease in some patients. This is the content of my talk today. So going back to statistics and numbers, the prevalence of IBS in general population can reach up to 15 or even 20%, and I'm here talking about Western population. And the prevalence of inflammatory bowel disease is very rare when compared to IBS. And the prevalence of ulcerative colitis range between 8 to 15 in 100,000, and for Crohn's disease is between 2 and 16 in 100,000. And the prevalence of IBS in patients with inflammatory bowel disease can reach up to 40%. As we mentioned before, having IBS increase the risk of future development of inflammatory bowel disease by 5 to 10 folds. Both of the disease, they are chronic disease, and one of the problem for inflammatory bowel disease is that there is no single test to rule in or rule out inflammatory bowel disease, to rule out or rule in irritable bowel syndrome. And there is a lot of similarity between the two diseases. And this is just to refresh your memories with regards to Rome criteria for diagnosis of irritable bowel syndrome. So if having a patient or individuals with inflammatory bowel disease but undiagnosed yet, they may present with vague abdominal pain and diarrhea, which are the core symptoms for IBS. So all of the above may lead to delayed or misdiagnosis of less severe form of inflammatory bowel disease, and prodromes of between 4 and 4.5 have been reported. And I mean by prodromes is the time between onset of symptoms and the correct diagnosis of inflammatory bowel disease. In this study, which is for a prodromal of irritable bowel syndrome, may be responsible for delays in diagnosis in patients presenting with unrecognized Crohn's disease and celiac disease, but not in ulcerative colitis, which was published in 2011. A 683 biopsy-proven patient with celiac, ulcerative colitis, and Crohn's disease completed a postal survey, including assessment of prodromal periods and IBS symptoms during both the prodrome and at present, and they were compared to age and sex match control. So this is the finding. Sorry. Yeah, so for celiac disease, yeah, they divide the two group into a group with a prodromal IBS. That means they have or they fulfill the criteria of irritable bowel syndrome before diagnosis, and those patients who had symptoms but they don't have or they didn't fulfill the criteria of IBS. So they end up with 67 patients for celiac for celiac for non-prodromal IBS. And I'd like you to focus on the number of years for delayed diagnosis. It was 10 years for celiac for those who have IBS symptom, and 7 years for those who don't have prodromal IBS with a significant p-value. And again for Crohn's disease, those who had IBS symptom, their diagnosis got delayed for 4 years, and those who don't or didn't have IBS symptom, they were diagnosed within 2 years with a significant p-value. But those who had ulcerative colitis, it was the same in both group, and this may be explained by that patients with ulcerative colitis, they present usually with urgency and bleeding per rectum, which is alarming symptom for both the physician and the patient himself, which will further require urgent referral for colonoscopy and further workup. Again, this is the same finding, so we can, from this diagram, we can see that having IBS symptom delay the diagnosis of celiac for about 3 years, and in general, for ulcerative colitis, there is no impact of having IBS on delaying diagnosis. While in Crohn's disease, it increased or delayed the diagnosis by 2 years. Another study, it was talking about prevalence of symptoms meeting the criteria for irritable bowel syndrome in inflammatory bowel disease patient. It is a systemic review and meta-analysis. They end up with 13 studies, 6 for adult and 7 for children group, and a total of 1,703 patients, and the pooled prevalence of IBD in all the group was about 40%, and for those with IBD in remission, it was 35, and those who had active IBD was 44. So it indicates that there is high prevalence of IBS among patients who had inflammatory bowel disease. Again, this is the proportion meta-analysis plot for prevalence of symptoms meeting criteria for irritable bowel syndrome in patients with inflammatory bowel disease, and we can see it's very close to 40%. This table represents the odds ratio and comparing odds ratio for IBS in IBD patient versus control. So we can see here that IBD patient versus control without IBD, they have about 5 odds ratio, and those with IBD in remission versus control, also it was about 5, and active IBD patient versus IBD in remission still high, approximately 4. Also, if you look to the bottom of the table, you can see presence of irritable bowel syndrome was more than 1 or more common in Crohn's disease compared to ulcerative colitis. The same thing, this odds ratio meta-analysis plot, it's comparing ulcerative colitis with Crohn's disease, and we can see that it is, the odds ratio is more than 1 when we compare ulcerative colitis to Crohn's disease. Regarding the risk of inflammatory bowel disease and diagnosis of irritable bowel syndrome, this is a retrospective cohort from US military, and they identify about 9,341 IBS cases and match to control of 18,678 patients, non-IBS patients, those from orthopedic clinic or primary care clinic without GI symptoms. And they further subdivided those patients with irritable bowel syndrome to well-defined IBS or others. And well-defined IBS are those patients who underwent colonoscopy and it turned to be normal colonoscopy within 12 months. And it is clear that the incidence of IBD was higher in the IBS group, as I'm going to show it here. So the continuous thick line represents incidence of IBD among patients who have IBS compared to other group, control group, or those who don't have irritable bowel syndrome. So the question now, how I distinguish between irritable bowel syndrome and inflammatory bowel disease. All of us, we know that IBS is a diagnosis of exclusion, which diagnosed on a clinical background, and if you'd like to go further to exclude other disease, you have to do a lot of biochemical tests and endoscopy and imaging, which is actually, this is going to lead to extensive and invasive intervention, and it is uncomfortable to the patient and inconvenient and has a high cost. In addition, simple tests, as it has been mentioned yesterday, such as CRP and ESR and other biochemical markers, they are non-sensitive and non-specific. And this is probably because these markers can be affected by malabsorption, poor nutrition, and drug therapy, as will other infection or inflammatory process. Calprotectin, which is a neutrophil-derived protein that can be measured in the stool, is now emerging that it can solve some of these issues. And it's unlike CRP and ESR, the level of calprotectin is not affected by inflammation other than GI. So in BMG, there was a study regarding fecal calprotectin screening of patients with suspected inflammatory bowel disease, and it was a meta-analysis to investigate the accuracy of this test. They include 13 studies, and if you can see here, this is the adult group, this is the children group, but we will focus on adult group. The true positive was 30, and the false negative was 2. So we are talking about a prevalence of 32% of inflammatory bowel disease of patients having positive test of calprotectin. And again, this is the forest plot of sensitivity and false rate. So we can see this is the adult group. It is very close to sensitivity, close to 1, which was about 93% in this study, and the specificity was about 96. And this is the Fagan nomogram. And we can see if we consider this pre-test probability was 32% on the left side. The upper line represents the post-test probability of the test if it is positive, which can reach up to 93%. While the lower line represents the normal test or negative test. So if you have a normal test, the chance of missing inflammatory bowel disease is about 3%. So, but we have to be careful about interpreting of these data, as the emphasis in tertiary care center is to rule in a disease, which is different from primary care, whereas your rule is to rule out a disease. So. Sorry. So, for example, if we reduce the prevalence of this test to 5%, this is going to increase the positive predictive, to decrease the positive predictive value to 55%, but at the same time, the negative predictive value, which will increase to 98%. So we have to be careful in interpreting this data. So if you are working in a tertiary care center, is different from someone who is in the primary care. So the benefit of this test is to rule out inflammatory bowel disease and decrease referral to endoscopy unit in tertiary care center. So in summary, High suspicion is the key for early diagnosis, as pathognomonic sign or symptom for IBD doesn't exist. And to be honest with you, it's very difficult to define what's the meaning of high suspicion. But what I found that having a diarrhea or having a diarrhea for more than 4 weeks, or abdominal pain and diarrhea, and persistence of symptoms for more than weeks, and also presence of rectal bleeding, weight loss, and other alarm symptoms, it should raise your suspicion for inflammatory bowel disease. And testing for fecal calprotectin is a useful screening tool to identify patients who are most likely to need endoscopy for a suspected inflammatory bowel disease. I will end up my talk by this diagram. And this is, if you have a patient with suspected inflammatory bowel disease, screen him with fecal calprotectin. If it is positive, you should send him urgently for endoscopy to rule out inflammatory bowel disease, while if it is negative, you can continue monitoring the patient. Thank you.